I think in terms of toxicities, anytime we add therapies, we're going to add toxicity. For example, when we add chemotherapy, we start to get the chemotherapy toxicities, nausea, hair loss, low blood counts that we have to worry about. And then with adding addition of a CTLA-4 inhibitor, we increase the incidence and severity of some immune-related adverse events, in particular colitis or GI toxicity, and this is something we have to be aware of. But I think when we think about these therapies, their potential for durable remissions in metastatic disease is so profound that finding a way to get patients safely on immunotherapy is important. Thinking about their molecular profile, thinking about their PD-L1 status, and thinking about their disease state as we try to select their best immunotherapy option allows us to counsel the patients and their caregivers on these toxicities to make sure that we can intervene before they become a problem for patients. So antibody-drug conjugates are really a revelation in non-small cell lung cancer. We have approval of datopotamab, a TROP2 targeting antibody-drug conjugate, as well as Teliso-V, which targets MET. And we're going to have several other likely approvals of antibody-drug conjugates. These are ways of precision delivery of chemotherapy. And so they have toxicities that you expect not only from the antibody, but also the chemotherapeutic component, but sometimes emergent toxicities you don't expect from either, such as interstitial lung disease. And I think understanding the toxicity profile of these agents is really important to ensure that we can safely administer these therapies, because currently these are approved in the refractory metastatic setting. And so the patients often don't have reserve to tolerate these side effects, but when they work, they can work very well, including in the brain. And so it's important for us to find how we can safely deliver these treatments to our patients.